thewellnesscouch.com, streaming wellness into your lives. Download the app today.
This is Up for a Chat with your hosts, Cindy O'Meara and Kim Morrison.
Here we are, up for a chat, talking about the hottest topics important to you, inspiring you to awaken the change within. I'm Cindy O'Meara.
And I'm Kim Morrison. Oh, what a treat you're in for. We have the beautiful Dr. Nelum Dharmapriya. Beautiful Sri Lankan name. Thank you for allowing me to get my tongue around that one, but you are such a beautiful soul, and we are so excited to have you back on the show. We know that you obtained a diploma in obstetrics and gynecology. We also know that you're a part of the family planning and also the Australian College of General Practitioners. You are a well-respected doctor, but with a very big passion in women's health. And today, Cindy and I were very excited to have you back on the show because this just seems to be a very big topic at the moment. One, I think women are becoming more interested in their health rather than knocking their hormones or knocking their mid-waistline getting bigger. They're actually getting curious. Nelum, welcome to Up for a Chat. Welcome back again, you beautiful soul. And thank you for joining us. Would you mind, just in case someone hasn't heard our last show, would you mind just explaining to the beautiful listener, that you're from Sri Lanka and how you got into medicine and why now you're so passionate about women's health?
Well, yes. So it was a long time ago, Kim. I graduated 30 years ago now, this year. So I'm heading off actually to my graduation reunion for soon. But so I was born in Sri Lanka. I lived in Sri Lanka until I was 21 and always planned to do medicine in Sri Lanka. But because of political problems within the country, I then universities closed down at the time. So I ended up actually going to Scotland to study. And I graduated from the University of Aberdeen in 1995. It seems such a long time ago. And then, I was a regularly trained doctor. I always thought that I had really good training as a doctor from Scotland. And then I was a partner in a practice in the north of England for 7 years, and then decided to come to Australia and ended up in Brisbane and built my own practice, and that's where I still am. And really, it was just my own journey through menopause and realizing that I was talking to my patients. I always prided myself for being a good GP. I thought I care about my patient. I was giving them all the new science, but I realized that what I was telling them wasn't working for me. And then looking deeper into it really wasn't working for them either. And so that's when I had to kind of think, well, obviously, what else is there? I must look for something else. And in that process of looking, came across insulin resistance, metabolic health, and then the changes, which were really nutrition and lifestyle-based changes, completely changed my health and then my clinical practice. And now, my patients who I have nothing against medications, but there's something more important. We use nutrition and lifestyle, and then if there's a place for medication, that's where it comes in. So it is a passion because I found out that I'm a real nerd when it comes to biochemistry. I love it. I love reading about all of this stuff, and it works. When I see patients, like before the last 4 or 5 years, if a woman in her mid-50s came to me and said, Nelum, I'm fed up, I'm gaining weight, I feel miserable, you know what I'd say? I'd say, tough. That's just the way it is, right? But no, I completely, I was wrong. That is not the case. There is so much that we can do.
I love this. There is nothing more beautiful than a medical or any professional that has their eyes opened and is excited about another way of being. I'm particularly curious around the fact that everything you were telling your clients to do wasn't working for you.
Yeah.
And obviously there was a curiosity that got linked and opened up. But I really would love you to answer me honestly, how much nutrition training is actually done to become a medical doctor?
Well, I mean, we are going back 30 years, so I can't possibly remember anything. But was it because I wasn't given any training? I don't know. I can't remember. So the fact that I can't remember means that it obviously wasn't significant. And also, Kim, I think 30 years ago, so I started 35 years ago, right? I think science of nutrition was very early on. It was very young. It was a new science. So fine, I think 35 years ago, the fact that I wasn't trained in nutrition, I think you could maybe excuse. But it is inexcusable that to this date, medical students are still not getting that training. And we know that because in 2019, there was a study done about medical students and what nutritional education they got, and they were getting very little. So I mean, that is the point, that there is no training in nutrition. So this is why today's doctors really we don't know, unless people like myself who've had their own journey. And that's if you think of everybody who is in this space, it is somebody who's had their own journey, who's then realized that there's something beyond what we have been taught.
I think when you look back on your training, it's almost like, and please correct me if I'm wrong, it's almost like doctors are trained to be pharmacologists, not biologists anymore. Yet biology is the foundation of understanding, and your love of things like biochemistry, which takes it even deeper. Understanding the way the body works will then show you what the body needs. And I'm just curious as to, I suppose, and I don't want to again say it, is it money that's come into it? Why have you guys become pharmacologists, not biologists anymore?
Well, I think the answer lies in who funds medical education. So practically all universities are now funded, well, medical schools are funded by pharmaceuticals. So what is the benefit to treat these new emerging doctors that really what you need to do is eat well and be out in the sun and exercise and do all the things that we did historically? Who is going to benefit from that apart from us individuals and maybe the farmers? So really, I think there's a lot of agendas there, and unfortunately I don't think it's going to change because there's too much vested interests.
Yeah, I would agree with you on the vested interest. And I think I'm seeing a really huge turning happening, not only in physical health, but in mental health as well. And I've mentioned this a couple of times on the podcast where I'm starting to listen to psychiatrists who are now calling it metabolic psychiatry. Yeah. Or nutritional psychiatry or metabolic psychology or nutritional psychology. And each one of them came on board because they had their own health issue. And one of them, and I'm not sure if you got to listen to her at Low Carb in America, because you've just told us that you've been low carb in the US, and that's Georgia Edie, and she's been to Low Carb Down Under. But you obviously spent a whole day at Low Carb Down Under, which is in, really a bunch of medical doctors and I guess dietitians.
Well, a whole weekend. Friday, Saturday, Sunday. Yeah. A lot of learning. It was amazing.
So, and you did a whole day on women's health.
Yeah.
So let us know who's out there. What are they talking about? What is the latest thing when it comes to women's health as doing it naturally as opposed to not naturally?
The importance of having a whole day dedicated to women. And I think that in itself is so unusual. So it was amazing. I absolutely loved it. And I was so glad it was in Florida. So going from Brisbane to Florida was a task in itself, but it was so worth it. So firstly, I think, Cindy, there was so many points. Okay. Firstly, I think menopause hormonal therapy. Okay. I have been a doctor in the era when it was taboo. We were so frightened of prescribing to any woman this menopause hormonal therapy because of the potential negative consequences, such as breast cancer, heart disease, blood clots. All of these were things that were kind of, it was so, I mean, you probably have heard that as well. It was the same time, right? But really so much. So what, now I can't remember the speaker, but she was a very good speaker. And what she said, so there was a couple of things, and I think they're so important. Firstly, that the formulations that we're using now are very, very different to what was there 20 years ago. So the estrogen and the progesterone that we use are now body identical. So it is exactly the same, the hormones that we produce within our body that we actually have access to in menopause hormonal therapy. Secondly, the way that we administer them now, the estradiol, the estrogen bit of it, we apply to the skin. So therefore, it doesn't go through the liver. So then we have all of those, the side effects that you get from this medication going through the liver is now mitigated. And then the progesterone, so the progesterone is the body identical hormone, and it is quite a large molecule. So we really can't use it through the skin, but it has been micronized. So it has been made into tiny particles in a capsule form that when we swallow it, it gets digested it gets absorbed very easily. So the products are different and the application is different, which has really changed the long-term outlook of these of menopause hormonal therapy. And the recommendation is really that women so the benefits, we will use this for symptomatic relief. We all know how difficult it is when you're going through menopause. Hot flushes, night sweats, the cognitive, the word finding difficulties, the brain fog, poor sleep, irritability, anxiety, feeling of overwhelm, not feeling loved, difficulty with sex, all of these things and so many, skin crawling, itching, so many things that women go through. Firstly, those symptoms really will be treated. Well, there isn't anything better for those symptoms to treat than using menopause hormonal therapy. But the longer term benefits like cognitive function, I mean, I'll go into it in a bit because there's so much to say. Cognitive benefits. It is protective towards the heart. It is protective towards bones. So the bone health. So all of this, there's long-term benefit, and you're best to start the benefits. You get these benefits if you start before the age of 60. Not that there's a problem with taking them beyond 60, but the benefits are within 10 years of menopause or before the age of 60 is when you get all these protective benefits.
Nelum, can I just interrupt you there for a second,
Yes.
just before we go into this further? Our foremothers never had this. They never had the opportunity for drug therapy or this beautiful hormone therapy that you're talking about. Is menopause, it's sounding like it's a real problem, and yet it's a natural part of a woman's life. I'm curious why we have so many problems with it when potentially our great-grandmothers, our grandmothers even, didn't have anything to help them.
You're so right, Kim. And this was a real struggle that I had in my mind, because I really look at things from an evolutionary perspective. So yeah, I thought, and the recommendation currently for people now is that you could use this menopause hormonal therapy until the day you die. Okay, so that's like, oh my goodness, like, and so then it took a little bit of reading and listening for me to get my head around it. So firstly, there are very few mammals from a biological point of view that live beyond menopause. So as soon as their reproductive time finishes, they're dead, literally. Okay, so we obviously live a little bit longer. Also, if you look at the age of the what's the what do you call how long you live? The
health span or lifespan?
Lifespan, sorry, of women in the 1900s were not much longer than 50, not much higher than 50, right? Apparently I was surprised at that. So now we're living, 30, 40 years beyond our reproductive age. So I did wonder, because at the end of the day, all medications have only been around for 60 years, right? That's it, 60 years. So how can we know all of this? And I think the way I'm going to use this is that I will use it in my patients and myself for as long as there is benefit. And then, beyond that 60, 65, just use it depending on need and what other research comes up. I think, there's a lot more research now happening in women, because when that Women's Health Initiative study came out in 2002, completely kind of causing this concern about hormone replacement therapy, it literally stopped the research in this area. So that was 20 years literally of research that we've not had. And it's only starting back, it's just started back in the last few years. So I think, there's a lot more to learn. And personally, I would say, for me, I would say watch this space, because I don't know whether, we can use this long term. I don't know. I don't think anybody really knows, even though what is being said at the moment is that as long as you are on menopause replacement therapy, that is the benefits, the protective effects persist as long as you are on. So particularly cognitive and bone health.
So are there any side effects apart from the benefits, like bad side effects, as a result of the micronized progesterone and the estradiol patch? Are there any side effects that they know of?
Listen, there are side effects, but I don't think they're as bad as we initially thought they were. So obviously there are headaches. You can get breast tenderness and those kind of symptoms, but I can't seem to find a huge amount of other side effects, not like we had with the older products that we used to use, because the older products, the estrogen was an equine, so it was from a horse derived estrogen, and the progesterone wasn't progesterone, it was a progestin, something similar to progesterone. So those are what caused most of the side effects. So because this is body identical, there's not a huge amount that I can find. But I think, you have to, obviously you start slow, you monitor regularly, and you have to see how things go.
So how are they making them then? If they're not, because I've always known they've used horse urine in order to get hormones. They do that with HCG. They do that with, a lot of the hormones that we use. How are they making it? Is it made through the synthetic biology? How's it been?
Well, the the estradiol, which is the estradiol, has been around for a while now, because we use estradiol in some of our, in the combined the pills that we use as well. So I think that, I don't know how it's made, Cindy, but that, I think that has been, they've been able to isolate that. The progesterone comes from a yam. Yeah, it comes from a yam.
Yeah.
So that's the difference. And this is, yeah, so it is a new, so this, the progesterone. So yeah, so this is what they're doing. And obviously, I don't know where they, I mean, obviously it's made in a lab. Yeah.
I remember when I was in my 40s, probably, I had breast tenderness or lumps. I really had kind of lumps. And my sister suggested I use a cream, which was a yam cream.
Yeah.
It's called Anna's Yam Cream. And it worked an absolute treat. It was absolutely brilliant. So I get that from the yam. But that was put on your skin. You put it on your breasts, you put it on your tummy, and in between the thighs of your, in your thighs, all the soft bits. And I never had lumpy breasts after I took that. And I used it for quite a few years. And then I went into perimenopause, I guess, or menopause, and I didn't need it anymore.
Yes.
But I do have a question that it's the same estrogen that is used, and I understand a young woman is very different to a woman in menopause, but the pill, that's using that same estrogen, sometimes these women come off it and they have all sorts of issues. So infertility is not really a care in the world for a menopausal woman. But what about skin issues? Like I have this friend at the moment, her daughter's come off the pill after 10 years. Her skin has it's angry on her face. And she came off it November, so we're 6-7 months later, and she's not doing well and doesn't know what to do. And
so she's come off her hormones?
Yes.
Yes. So could it be that her natural, so we need to look at really her, what her cycle is doing and what she's, where she is, because it can be an imbalance of the different hormones as well. And, so I think that's a completely different time frame, Cindy. And also so for her, it's probably, so you need to look at, well, what's underlying, what's the metabolic health doing as well, because insulin sits above estrogen. So if insulin is high, for instance, and she's metabolically not as good as she should be, then that is going to interfere with estrogen function as well. So I think you can't ever do anything in isolation. The human body is just amazing, isn't it? You have to look at the full picture, really. Yeah.
Beautiful, Nelum. Is there, I heard Dr. Libby Weaver talk a long time ago about well-meaning mums helping their daughters with skin issues or problems, and everyone does it with the right intention to put them on the pill when they're young. But one of the comments she made at one of her talks from a biochemistry point of view was, when you put them on this medication at such a young age, and I know this is completely different perhaps to what you're talking about, it takes 5 years during puberty for the biochemistry of a woman's body to actually get into a good sync and all of that. Now, if you go on any kind of hormone therapy, contraceptive therapy when you're young, then when you come off it, you're going to then have to use the next 5 years for your body to do what it was meant to do in its teenage years. That's how I heard her talk about it. Is this the case? If you start this bioidentical hormone replacement therapy, are you on it forever, or what happens? Do you gradually come off it? What's been your experience as to understanding? Because I'm sure many women are going, I'd do anything to change these feelings. But then, like you said, is there long-term ramifications?
So I think, Kim, your point about young women, this was recently something that I was reading about, and it really did worry me, because because the pill, is there for managing these very erratic cycles, managing heavy periods, for particularly for young women, and now very young girls, even as young as, I remember seeing, I had my youngest young girl who started on this by her pediatrician was, I think, 9, because she had such heavy periods that she wasn't coping. And at 9, it is hard if you're flooding and, all of that. But you're right, because this cycle of estrogen, progesterone, all that incredible cycle that women go through, for young women, it is incredibly important for their brain development. Apparently, this is something that I recently read. And so what we're doing, suppressing this up and down, these cycles that we naturally supposed to go through, is it the right thing? And this is only a very recent thing that came into my head. So it's really difficult. And the answer was, as a society, we need to understand and manage these problems or these symptoms in a different way. I think that's going to take a long time, because young people, they're not as resilient, I think, as maybe the older generations were. And maybe as parents, we are to blame for that. We're very, we kind of want to make life better. So it's going to take a whole, society talking about this before, I think, this message gets out that maybe we don't do the suppressing hormones, and we find another way of managing heavy periods and contraception. And it's going to be a tough discussion, I think that.
I agree. I think it's going to be a really tough discussion because, we're so used to a pill for a malady rather than a lifestyle change for a malady. So, and that's where I want to talk more about. So you talked about insulin and estrogen and, their relationship. Could you talk more about the relationship of metabolic health, insulin, estrogen, and menopause? Can you talk about that? Or even PCOS and endometriosis and all those things that no one talked about this stuff when I'm 65.
Yes.
Nobody talked about this stuff when I was a teenager. I don't remember any of this. The pill was just kind of starting, I think.
Yes. 1964 is when the pill is the first long-term medication that we had. So that was first given in 1964. So it's only the last 60 years that we've had this medicine that we use long term. So, all right, Cindy, there's a lot, and I think it's really important. So let's just briefly touch on PCOS, so polycystic ovarian syndrome. It is essentially a problem of insulin resistance. Okay, so it is, and generally there's an inherited component. There's usually like a family history. It doesn't mean that just because you had somebody, your mom had it, that you're going to get it, but you're going to have a higher susceptibility. Okay, and what happens there is this woman has a degree of insulin resistance, and when there is high levels of insulin, what happens? So I'm going to be jumping up and down here, but our estradiol, which is our natural estrogen, is produced in the ovaries, okay, and also in the fat cells as well, and it is produced from testosterone, right? Yes. So in what happens with insulin resistance is that it's called, in the fat cells, there's an enzyme called aromatase which converts the testosterone into estradiol. But when there's insulin resistance, that process doesn't happen. That aromatase is inhibited. So this is what explains all the problems that women have during PCOS, because They have more androgenic effects. So, the acne, the excess hair growth, they have lower estrogen. So that's why they get, the skin breakouts and things like that. They also have an imbalance with the progesterone. So, all of these things is what accounts for the changes in PCOS. Endometriosis. I loved going to this thing in January because I learned a completely new thing on endometriosis. And so I don't know how much you know about endometriosis, but so basically endometriosis means that we find the endometrium is the lining of the uterus. Okay. And in women with endometriosis, we find this lining outside the uterus in the abdominal and pelvic cavity. So how did it get there? Right. So we always thought it was something called retrograde menstruation. When you menstruate, you get blood coming out of the vagina, right? But also there is, you get this blood also going through the fallopian tubes out into the peritoneal cavity. So the cavity, the pelvic cavity. And that's what was thought to happen. But now what they've found is there's a connection between the gut and this retrograde menstruation. Okay. So what happens is that if you have a gut dysbiosis, so if you've got a gut microbiome that isn't healthy, and you have a leaky gut, that causes an inflammatory process, so there's an inflammatory process that's already started within the pelvic cavity. And so then through retrograde menstruation, when you've got this blood and things like that are extruded out into the pelvic cavity, this then triggers, how do I explain it? The inflammation has already started. So this is now, it works as a substrate for that inflammation. So now what they're saying is it's the gut dysbiosis and leaky gut that actually is the cause of endometriosis. So we need to focus on managing the gut. Because what we do now is we surgically remove these areas of endometriosis that you find in the pelvis. So we'll remove them, but it doesn't sort the problem out. How have you heard of? There's so many people who have had this extensive surgery, and then a few years later they have symptoms again because the actual problem hasn't been dealt with. And then the medication that we give, we give medication to completely stop ovulation. And sometimes the pill is used for that, sometimes much stronger medication that induces like a menopausal state. So these are very strong medications that we use in younger women who are still menstruating, because these are the women who get the problems. So if we're saying that we need to talk about the gut, that's like massive.
If we could look at the way you and Cindy think around nutrition, and we take good care of ourselves, we're getting enough sunlight, we have a real strong sense of self, and we feel good about who we are, we feel like we're contributing, all of the things that make us feel whole and loved and contribution, and we're eating well, we're moving well. Does all of that affect menopausal symptoms, all the negative ones that you're talking about? Or does the menopausal symptoms happen, which then changes all our emotional state?
I think that goes both ways, Kim. I think if you are metabolically well, so listen, at the end of the day, all women will go through menopause, and that process is quite difficult for women because we have estrogen and then we don't have estrogen. It's a withdrawal effect. So we've had estrogen for most of us 30, 35 years, and then we don't have it. Okay. So that process we all go through, and some women are affected more than others. But so those symptoms that I talked about, the hot flushes, the brain fog, the sleep, all of that, there will be, because estrogen has, there are receptors in the brain. There are estrogen receptors in the brain and in key areas. So in areas that affect memory, in where it affects, how we control body temperature, our sleep, in areas where, what else? Memory, emotional regulation. So it was less than a year ago that this study was done that found that the brain has these estrogen receptors. So every woman is going to go through some of this. However, if we do not manage our metabolic health, so we'll say this. So it is important to replace that estrogen, or maybe it is important to replace that estrogen. But replacing estrogen isn't enough if you don't do any of the stuff that improves your metabolic health. So it really has to go hand in hand. Because the thing is that a reduction in estrogen also causes a decline in your metabolic health as well. So it goes hand in hand.
Okay, we're doomed.
No, we're not. No, we're not.
I know, but I'm just joking, thinking, look at a woman's life. She's a young little girl. She thinks she's a princess. Then she starts getting pre-teen. She starts getting hormonal fluctuations. I mean, boys' voices break and their balls drop, yes, but we get breasts, we get period, then we bleed. And then we have up and down emotions and all sorts. And then we fall pregnant. And then our whole body gets opened up to the world and it becomes a milk truck. And then it's like and then we're meant to still service our husbands and partners and be happy about giving everything to everyone. And then you throw menopause at us. And now, because we're having babies older, we have teenagers while we're going through menopause instead of them moving out. So throw me under the bus. Now I'm out.
Yes, it is. And truly, that's why. So, and, like Cindy says, it's not just, so you can't just give this hormonal therapy and expect it to just sort everything out because of all those things you said, Kim. Not only do we have teenagers, we're also looking after elderly parents. Right. And then
husbands going through a midlife crisis wanting to buy a bloody Harley or something.
So it's so much bigger than just giving menopause hormonal therapy. We have, and I think mindset and really looking, I think the other big thing that's coming, and everybody at this Low Carb Conference talked about it, is the impact of stress on your body. I think we completely underestimate that. And I think that this year, I'm really kind of looking at that. I feel that this is where everything at the end of the day boils down to how we perceive stress, how we manage it.
And it is perception, isn't it? It's like some people, something will happen to them and they won't see it as stressful at all, whereas another person will see something and say it's stressful. Like Kim and I went on a hike and we saw a snake and it was a copperhead and it was within a meter of us, And I think that's a normal stress.
Yeah, exactly. But and it's also it's an acute stress. So if you kind of think, oh, who cares, and you stepped on it, then you'd be dead most probably. But you needed that stress reaction at that time to say, oh my gosh, what is this? Jump away, do whatever you have to do, and then you half an hour later, you can say, oh, thank goodness.
We laughed.
Yeah.
And we shook it off.
Yeah.
We did. Nelum, I just want to say thank you. First of all, it takes beautiful women like you and doctors like you that are still curious to want to learn and don't feel like just because they've got a degree in general medicine that they know it all. If anything, it's potentially for someone like you opened up your heart to realizing that there is so much more to know, and particularly as the science is changing. How much, in your experience, in the 30 years you've been practicing medicine, how much has the gut health, gut microbiome, and the link between the gut, the brain, and our hormones and everything, how much have you noticed an influx of information, and how important is it? And do you think we've hit the pinnacle, or is there still so far to go?
Oh my gosh, there's so far to go. I had no idea about gut health at all. Apart from, the basics that you learn, gut microbiome, I didn't know what that was, right? That until just maybe the first time I heard it was probably about 6 or 7 years ago. And it's really since I got stuck into metabolic health that it's completely opened my world. And I think we have no idea about the impact it has on us yet. I think there's so much more to learn, because things like we talk about the gut microbiome, but we don't really know enough to say what is good, what is bad. We have some indication, but we don't know enough. And I think there's a huge, there's so much more to learn, and particularly the gut brain axis and the impact on our on our emotions, on our mental well-being, on all that, and the psychiatric manifestations of this, neurodegenerative conditions. So, oh my gosh, I think there's so much to learn.
Do you think that the reason why the gut and the microbiome and all the things that we're figuring out about it have been highlighted because there are so many people now with dysbiosis, irritable bowel syndrome, Crohn's disease, even celiac has risen? It's almost like we had to destroy what we didn't know was there to find out it was there, to find out its function, to figure out how to now get it back. Because I know back in my day, so if I look back in the 70s, I knew one girl with one sister who had celiac disease. That's all. I'd never heard about it before. And when she said she couldn't eat bread, I went, what? She can't eat bread? So this was the 70s. Then in the 80s, when I graduated, so early 80s, I graduated, we still weren't being taught about the gut and the microbiome or anything like that. It wasn't until, I believe, this is what I believe, genetic modification of foods and the onslaught of glyphosate, which is a patented antibiotic, the increase in ultra-processed foods, the fact that we don't go outside, see the sun, don't go into nature, think we should be in clean, pristine environments, being scared of bugs, you got to wash your hands every minute of the day. Do you think that has created this crazy, it's not crazy, but this unbelievable knowledge that we've had to have in order to figure out what we've got to do to get it back? It's almost like we destroyed it and now we've got to try and figure out, get it back. And I don't know if we can get back the diversity.
We'll never get back the diversity.
Yeah.
Never. I suppose fecal transplants and things I know it's happening, but they say that even the most healthiest of modern humans that live in urban areas, we will never have the diversity that people, of our ancestors or people living in very rural, remote areas. Kim, Cindy, I don't know. I wonder if because we are so pharmaceutical heavy and pharmaceutical, research heavy, that there hasn't really been a focus on looking at, who does the research on the gut, because it's really who benefits from that research. So I think a lot of the lifestyle and nutritional studies are really, we don't have funding to do this research because it's expensive to do research, as you know, and who does them? Who has the money to do it? So I think that's probably why it's taken so long, and I'm so glad that people are actually doing it, and whoever is funding it is funding it for the right reasons. But yeah, I think I'm glad that we finally kind of and I think really to learn about these things, there had to be technology, to look at these microorganisms that you can't actually even see, that they're not visible to the human eye. So to actually be able to look at them, look at their genes and the way, their all of that, I think, I suppose it just needed to kind of gradually evolve.
So if we do wipe out, our diversity, we know what it's actually doing to ourselves. And you talked about fecal microbial transplants and how that's helping not only in physical but mental, as well as irritable bowel and so many getting rid of Clostridium difficultus, as whatever you call that thing. And I just wonder, are we going to, and I guess this is a really serious question, but are we going to create such low biodiversity that we will change the health of humanity forever? Or we're starting to find new ways, such as nature, spore biotics, pre, post, and probiotics. Do you think we'll get that knowledge before we destroy it completely? Because, you look at most of the people's health around, even people who really work hard, they're not doing as good as they should be doing.
No, and because the other reason is that our microbiome is not just has not been just up to us. It is influenced by our mothers, our grandmothers, and I think our great-grandmothers. I think it's 3 generations. So, and it depends on, what our mothers, what their pregnancy was like, how we were delivered, what were we breastfed. So there are so many aspects that we have no control over. And Kim, you were mentioning about Libby Weaver, and one of the things that she says, she gives this, I don't know whether you've heard this beautiful, if you think of us, here we are, modern humans, 2025, we're the most modern humans that there is, right? But our genetics, they really haven't changed when you compare it to the oldest humans just like us who've lived on this planet for 200,000 years ago. So if you take that 200,000 years and condense it into a 12-month period, just so we can get our head around it, the last 75 years that we call the commercial era is just one footstep in time, right? So imagine here we are in this modern space age food environment in a prehistoric body. And no wonder these things, they cannot go together. If it has taken 200,000 years for really nothing to have changed about our genetic makeup, it is not going to change in 60 years just because we're saying it. That's not what's changed. What's changed is our environment. So, Cindy, yes, I think eventually, unfortunately, our human bodies will be able to process this rubbish. It'll take another 100 to 200,000 years. But this is the mismatch. And I think it's when you understand that, what did humans eat for all of that time that they've been on this planet? Not just eat, but do, right? And what are we doing and eating? There's such a mismatch in that from an evolutionary point of view. No wonder we're so sick.
Yeah. Definitely. So tell us about some of the other speakers that you were really impressed with. Seeing nobody else, I didn't get to go.
Yes.
At Low Carb.
They weren't many. There was just me and another one Australian.
Yeah, so. I love Low Carb, I love Low Carb Down Under as well. I think they do an amazing job of bringing incredible speakers to Australia. So who else really?
So then there was a young cardiologist, Lily Johnston, she was. And she was so good. And what she said, and I think this is something that I think we don't think about being women, is that still the thing that the thing that kills women is heart disease. 1 in 3 women will die of heart disease. And the problem is that for about 64% of women who have a heart attack, they wouldn't have had any symptoms prior to that. So women, when firstly, women present differently. They don't get help as quickly as they should. So she presented that it takes an average, this is in the US, I can't imagine that it's very different here. It takes an average of 57 hours for a woman with heart symptoms to access help, medical help. Right, 57 hours, and I think for men it was 15. And we say to actually get the when somebody has symptoms of a heart attack, so angina, whatever, the earlier you get in, the better. So it's because women put everybody else first, right? Oh, my child needs this. Oh, my, this, I have to cook the meals, this. And if it persists for beyond, if it's still there tomorrow, I will go. So women present late, they present with symptoms that are not typical. And because of that, they don't get the same treatment, and they are more likely to have adverse outcomes from these heart symptoms than a man. So I thought
that's insane.
Yeah, that's right.
Now, and what's it like then for you as a doctor? We'll come back to the other speakers, but just in that moment there, a lot of people just go to the doctor because you're the local doctor to go and see, and that you're the closest to them. So they may not have any understanding about microbiome, gut health, hormones, nothing. They've just got a symptom and they want you to give it a pill and to go away. Yeah. Do those people get pleasantly surprised when you start asking about sunlight and stress and lifestyle and foods and microbiome? And then what's the other side? Do people actually seek you out knowing you are a more holistic integrative doctor? Like, what's the ratio there?
Yeah, no, it is definitely people are seeking me out now that there's your podcast when I was on that, really, I think there was a lot of your listeners, many of them, quite a few of them who came to see me who are still now my patients, so which is lovely. And then on various social media posts, now people know me. But the way I manage I would say 90% of people don't know this stuff. So when they come in, my initial appointment is a 15-minute appointment. So I can't go through this whole thing with them. But the way I do it is I will say, is it worth doing a metabolic health screen? And as I say, this is my special interest. And I feel that, we're looking for the root cause of things, and let's just have a look and see where you are. And then when you come back, book a long appointment. So then I have a half an hour to really go through these things with them. I show them, I think the blood test is really important because you can show them where it should be and where they are. And then for some people, it is enough to say, I want to learn more. How can I change? For others, there are so many other priorities that it's all right. They will eventually get there. So sometimes it is frustrating, particularly for my own patients who I've been their GP for the last 15 years. There are some who are still kind of not on board, but that's all right. They will get there.
They might get a pharmaceutical medication to help them. No, I'm only kidding.
Doing mind-altering psychotherapy or something.
I think you're so exceptional, but sorry, I was loving your conversation about the low-carb speakers. Sorry, Cindy, were you going to jump in with a question?
I kind of think, because I've just opened up the page of all the people who spoke there, and it looked like there were some, and I've just looked up Lily Johnston, so I'll read about her and listen more about her. So I'll find that out. And people can do that. They just have to go, low carb USA, Florida, and it'll come up and all the speakers come in, and you can actually order all the talks as well. So if anybody's interested, they can do that. But where I'd like to go now, I always want to go somewhere with you, Nelum. But where I'd like to go now is, so number one, where do people find you? And especially people who are maybe going through menopause and having problems, and knowing that you do a very integrative approach where you're not just about lifestyle and you're not just about drugs, but you're about going across the board, looking at their metabolic health. So number one, where do they find you? And number two, if somebody walks in and they want to go through the process of learning about their metabolic health screen, and the reason I'm asking this question is that I haven't had a blood test since 2016, and I finally went and got one done, and I had a quite extensive one. I asked for the extensive one that I had, and about 2 weeks later, I rang my GP, who has known me for 35 years and always says, "What do you want, Cindy?" Not, "How can I help you?"
Yes.
He knows us, doesn't he, Kim? He's both our GP. And so anyway, I rang him and I said, "Why haven't you rang me about my blood test?" "Well, I don't have a copy of it, And he goes, "There's nothing wrong with you, Cindy. It's perfect." But there is something wrong because I have symptoms.
Yes. So firstly, where can people find me? I am at Narangba Doctors. So Narangba is about, so it's Moreton Bay, and I'm about 35 minutes from Brisbane. So I am now open to new patients because I've changed the way I work. So I only work 3 days a week. So, so people can call Narangba Doctors reception and book in. That's fine.
Good.
So, Cindy, going to your point, so I think it's really important to know blood results. What I look for is optimal levels. So for instance, let me tell you an example. Vitamin D, when we check vitamin D, the optimal, it says anything above 49 is normal. Do you know that level is to prevent rickets, right? Rickets is the bow-legged young kids that we used to see, many years ago. And so anybody who has a level, and this was me as well, of 50, 52 is like, oh, that's fine. You're fine. But that is just the minimum amount you need to get to prevent rickets. That's not optimal. So when you're looking at the blood test, I think you need to be able to see that the reference range might not necessarily, you don't want to just be in the black, not in the red. You also want to have, want to know what the optimal levels are. So I would get your blood tests, and you can get them through, you should have it on your My Health record and have a look at them because you probably know all the levels anyway. So I think it's really important to do that because it is important because things like liver function tests, since I graduated 30 years ago, the reference range has changed, okay? And that's not because somehow, the reason the reference levels have changed is that in the population, there's much more of things like fatty liver. So that then changes the reference range. So now this particular liver function test called ALT is abnormal if it's above 45. But actually, when we're looking at it, we want it to be less than 25. So so these things, unless if you're just looking at, that was me, I'm not, I used to just look at the thing and think, no, everything looks normal. They're all in the black. There's no red there. Fine. You're fine. But you might not be fine.
There's actually, if you Google reference for blood test results for optimal levels and look for images, there are some charts in there. Maybe, Nelum, this is a request for you to do one because we trust you more than anyone else. But that would be a super cool thing to download to see, because I know when I got tested in the UK many years ago, they said my iron levels was normal. So I didn't give it any more thought, even though I was constantly tired. When I came back to Australia and got my iron levels tested, they said I was low. So even within countries, The
Oh,
optimal
yeah.
ranges are
Yeah.
very different, and I don't know why, but this is just something that would be really helpful, what we're looking for, because I get my blood test results back and I look at a whole lot of numbers and
And
funny little symbols, and I go, right. And then I remember my naturopath saw one of my blood test results. I went back to a doctor that was a locum at the time, and she said, well, I don't know, I'm not really interested in that. And I said, but my naturopath said that this is a questionable thing. And she goes, well, you didn't come here for my expertise in that, and I don't agree. And it was like, oh, this is really challenging because she wasn't even trained in that. So how do we, as lay people, when we go to a doctor and say, look, I'm not feeling 100%, could we do blood tests? Some blood tests cost us money, and then there's urine tests that can cost us money. And then, as Cindy mentioned at the beginning, full blood tests. Like, some doctors don't even ask for that because they assume we don't want to pay for it. Well, I'd rather pay for something to get the full spectrum.
So this is such an interesting point, Kim, because I was listening recently to there's 10 GPs here where I work, and we it's a really lovely team. But I realized, I'm going to say it because I'm a doctor and I can say it, we're very pig-headed and very narrow-minded, okay? And so I was in the tea room and there was a discussion going on about some test that a naturopath had ordered. And it was like, why should we do it? And how do I interpret this? And if I don't know how to interpret it, how can I give? And that is true. If there are tests that we are not regularly requesting and somebody else requests it and we have to request the test, and then if we don't know about it, it's very difficult to interpret it. So the responsibility of a clinician is not just to order a test, but also to know enough to be able to interpret it. So there is that difficulty. So if there are certain tests that really we are not, GPs aren't kind of regularly, and then so even insulin, unfortunately, insulin, even though it's very straightforward, has never been part of general, we don't test it. It's only in the last 4 years that I've been testing it. And then 90% of like my other colleagues don't test it, right? So it is difficult. But I think there's also this, unfortunately, this unwillingness to maybe look a little bit more. And, I've been doing this stuff for the last 4 years, and it's only just last month that a couple of the GPs said, we haven't had an education event with you, like you explaining this stuff to us. And I'm like, I'd love to. So now we have a date. So that took 4 years. But it is difficult. And I can understand from a patient point of view how frustrating it is. And I, as a patient, I recently needed to, I've not had a GP. That's dreadful, right? And so finally I thought I need a GP because I'm fine, but I'm thinking of start doing the menopause hormonal therapy. I'm not yet 60, so I thought I'm going to start it before then. I thought I better have a GP. And the process in my head that I had to go through, because you cannot be a patient or somebody who is on this metabolic health journey and have a regular GP. It does not work because it is completely opposite. So to find somebody who would, even if they're not necessarily on board, but is willing to listen, I think is the biggest challenge. And I think if you have a GP who might not know everything about metabolic health, but is happy to take on board some of this stuff and learn with you, I think that's the best option. But it is very, very hard. If otherwise, it's very hard.
And some doctors have such different interpretations of the results. I remember Libby was actually staying with me one night, and I got my blood test results back a week or so beforehand. And that doctor, I basically walked out of there and thought I had 3 months to live, the way she talked to me about my results. Well, that's how I heard it.
Yes.
And I was just like, I said to Libby, oh, my bloods are terrible. And she goes, let me have a look. And I said, no, I don't expect you to look. And she goes, yeah, I love looking at all this. She's a biochemist.
Yeah.
And she looks at it and she goes, oh, have you had an infection lately? And I said, yeah, I've just got over a really nasty flu and I had a cold sore. And she goes, oh, no, that's just a spike showing you're getting over a thing. No, she goes, your bloods for your age are amazing. What completely different.
But that's it. That's that being able to interpret it in that way. So, yeah, it is hard. It's hard, Kim, because that's not how we're taught. We're not taught the root cause. So to learn this stuff is asking a lot of somebody who hasn't had their own journey, because everything you learned as a medical student, as a doctor, you have to unlearn and learn something completely different. And, it is a lot to ask somebody.
But you've done it.
I have,
Yeah.
and I feel
if you can do it, everybody can do it.
Yeah, I know, but I know how much time it took me, Cindy, and I loved it. And I think, unfortunately, and this I'm going to say another thing. I think, unfortunately, this is going to be, if as a profession we are not open-minded, we will not survive.
Yeah.
I think doctors will not survive as we are now, because this is why people aren't getting the answers from their doctors and they're looking elsewhere.
This has been, we could keep talking, as you know, but this has been incredible. And I think it'll be good for people who are, questioning their own GP, and for women, and we do attract a lot of women on Up for a Chat. So for women that are looking at both sides of the equation rather than one or the other, I think, you've really explained this well, and explained the new HRT, I guess that's what it's called.
Yes.
And what they're doing. And I think it's been wonderful, and it's been a wonderful conversation. And hopefully we'll see more of you. And if, maybe we should ring you on occasion and do this on a topic. Yeah, just do it on a topic, and what's the latest on that topic. And perhaps if you have a topic that you think that people would be really interested in, maybe we do a whole thing on blood tests.
Yeah, we could.
Yeah, we could do a whole thing on blood tests, or I don't know what other tests that you do, but and especially like another one, and I guess they can go to your website for this, regarding metabolic health, because that's a journey.
Oh my gosh.
People back to metabolic health.
There's so much to say, because we've only talked about nutrition, but there's, all the lifestyle. And so I always start with food, because that's where people have the most control, we'll say. And then we expand out there. But yeah, I would love to do that, because I think there is so much that there is a lot and little things that make a big difference, I think. Yeah.
Nelum, just out of interest, I know you just done the Low Carb Conference. What's the next thing that's lit you up? Because I imagine someone like you learn something and then it opens up a whole new dynamic and you want to learn more about that. What's new for Nelum?
So there's so many. So vitamin D, it was like, whoa, there's so much. And I've learned so much about that. Thyroid, the fact that, we order such limited tests, and the realization that there's so much with thyroid, but still my hands are tied, because there's little that I can do about the more extended thyroid abnormalities. And there's so much. But the other thing is that I am speaking at Low Carb Down Under this year, Cindy. Yes, actually, I'm speaking on South Asian health, because that's my other passion. As South Asians, we are at a very high risk of metabolic dysfunction for many, many reasons. And low carb eating doesn't come naturally to to ethnic groups that grew up on rice and all carbs. So that's my message there is that there is a lot that can be done without giving up everything that you love. So yeah.
All right, we will be getting you back on. I think testing would be a good one that we talk about. And then there's so much to talk about. But on behalf of Kim and I, and Kim will thank you as well.
You're amazing.
Yeah, I know you are amazing. And I look for,
Well, thank you. I love chatting to both of you. It's great.
Oh, you're just incredible. And I particularly love and respect any avid teacher or professional who is so willing to constantly learn. And that's probably why I love Cindy so much and all the people in our networks, because every time we get together, and even when we catch up with you at the different summits and things, it's like, did you know this? And we all get so excited by the latest information. And I hope this podcast is doing the same for our listener. And just thank you for being you, beautiful Nelum. You're amazing.
Thank you. Thank you, ladies. It's been a joy to chat with you. Yeah.
This has been a production of TheWellnessCouch.com. Check us out on Facebook and join in the conversation on Facebook.com/TheWellnessCouch. Subscribe to each show on iTunes and check us out on Twitter. The Wellness Couch, streaming wellness into your lives.
Whilst the Wellness Couch presenter endeavor to provide accurate and helpful information to their listeners, these podcasts cannot take into account individual circumstances and are not intended to be a substitute for health and medical advice from a qualified health professional. You should always seek the advice of a qualified health professional before acting on any of the information provided by any of the Wellness Couch podcasts.